So this is my new home, Aspetar, and I am very, very happy to be here. I've been welcomed so sincerely by all of you, and it feels amazing to be a part of the Aspetar family and team. What I come from is the Karolinska Institute, and I've been active at the Karolinska for the past 20 years, doing both hand and orthopedic surgery and research. But the Karolinska Institute is probably most known for the Nobel Prize. The Nobel Prize in Medicine or Physiology is decided at the Karolinska Institute annually, and it's handed out by King Carl XVI Gustav in a very, very pompous and nice reception in Stockholm in December every year. But when it comes to proprioception, the Nobel Prize has actually been a key thing. So the Nobel Prize has been handed out to researchers for proprioception no less than 4 times. In 1906, the Nobel Prize in Medicine or Physiology went to Drs. Golgi and Ramon y Cajal for their studies on the structure of the nervous system and their descriptions of mechanoreceptors. The Golgi receptor, as a lot of you probably know, is found in the musculotendinous junction, but also in ligaments, for instance, of the wrist. In 1932, Drs. Sherrington and Adrian described their discoveries of neurons and how the neurons are sending signals throughout the body and connecting the somatosensory system. In 1944, Dr. Erlanger and Gasser described the different nerve fiber types. So we have the fast, we have the slow, we have the nociceptive nerve fibers. Also, they contributed to the notion of proprioception and how important it is to who we are and how we function. And lastly, the Nobel Prize in Medicine went to Dr. Julius and Dr. Patapoutian in 2021, so it was handed out just 1 month ago for their studies on the receptors for temperature and touch, and how we have protective reflexes based on both pain and temperature. But really, what is proprioception? Well, the word proprioception comes from Latin, where proprio means belonging to oneself, and ception means to sense. So in other words, proprioception is our sense of self. When it comes to proprioception, it was first defined by Sir Charles Scott Sherrington in 1906. He described this as the conscious and unconscious perception and regulation of posture and motion through stimuli originating from receptors in skin, joints, and muscles. So we have conscious proprioception senses and we have unconscious proprioception senses. The conscious ones pertain to tactility or the feeling of touch. We have joint position sense, and we have the sense of kinesthesia or joint motion. These senses primarily originate from receptors in the skin and in muscle spindles. The unconscious proprioception senses pertain to balance, joint stability, and what's called feed-forward control. Feed-forward control is basically the anticipatory control. So for instance, if you're a tennis player and you see that ball coming towards you, you don't have to think about how hard you're going to hit that ball because it's instinct, it's within you, and that is the anticipatory control. These sort of reactions are primarily generated in joints and in the spinal cord. Dr. Jonathan Cole is a British neurophysiologist who has done a lot of work on the senses of proprioception, and this is how he defines it. So we're talking about muscles and joints and skin. But let's look a little bit closer at joint proprioception. Because when I started out doing my proprioception research almost 20 years ago, there was very little known about how the innovation looked like, in particular in the hand and the wrist when it came to joint innovation and proprioception. The first innovation study in the upper extremity was published by Dr. Petrie in the British Journal of Hand Surgery in 1997. And since then, numerous studies have described mechanoreceptors and innovation in the wrist, distal radial ulnar joint, basal thumb joint, elbow, shoulder, and in the interosseous membrane of the forearm. 4 principal types of sensory nerve endings are found in these joints. By far, the most common mechanoreceptor is the receptor called the Ruffini receptor. This is a static receptor. It means that it's signaling all the time. And what it does is it signals joint position, the speed of movement. And so it looks almost like a tree, and the tree is branching out into the ligaments, and these distal fibers are hanging on to the collagen in the ligaments. And so as soon as that ligament is moved, the receptor is sensing that motion. The second most common type of sensory nerve ending is the Pacini corpuscle. Contrarily to the Ruffini receptor, this is a dynamic receptor, so it is only signaling when it needs to, and it signals acceleration and deceleration of motion. The third type of mechanoreceptor is named by the Nobel Prize winner Camillo Golgi. It's a Golgi-like receptor. This receptor is very rare in the hand and in the wrist. It only signals at the extremes of joint motion, and the only place we find it in the wrist is in the TFCC and in the subsheath of the extensor carpi ulnaris. And it sort of makes sense when you're thinking about it, because that is where we have global motion and rotation in the hand. The final type is the type called free nerve ending, and these are nociceptive nerve fibers, and they are prevalent throughout the hand, the wrist, forearm, elbow, etc. But if we look at the distribution of mechanoreceptors in the wrist, we will find that it differs. On the volar side of the wrist, where we have primarily very stout ligaments that are robust and they need to support the load transferred from the hand onto the wrist, we have very limited innervation. So we have stout ligaments, but almost no nerve endings. On the other hand, on the dorsal side of the wrist, where we have longer ligaments that are sensing motion, we have rich innervation. A similar pattern is seen in the basal thumb. On the volar side of the thumb, we have almost no innervation, whereas on the dorsal side of the thumb, we have rich innervation, in particular with Ruffini receptors. I'm not going to talk a lot about the basal thumb, but I will just mention it briefly, because basal thumb osteoarthritis is the most common type of osteoarthritis in the entire upper extremity. So we did a study where we looked at the innervation pattern in the ligaments of the basal thumb joint, and what we found was that we had significantly altered innervation pattern in patients with painful basal thumb arthritis. In these ligaments, we found no Ruffini receptors. We found a true predominance of pain fibers or nociceptive fibers. And when we looked at the synovium from these joints, we found a polymodal, so several different modes of neurogenic inflammation pattern. And this might explain why in basal thumb arthritis, it can be difficult to actually get pain relief in these patients, because they might have different ways of inflammation. So it needs to be attacked very individually in each patient. But it's interesting because a similar pattern has been seen in hip osteoarthritis. So in hip osteoarthritis, you will also lose mechanoreceptors and have a predominance of pain fibers. What we don't know, of course, is what came first. Is it the loss of mechanoreceptors that is causing osteoarthritis, or is it the osteoarthritis causing the loss of innervation? So we know that we have sensory nerve endings in the wrist joint, and we hypothesized that these nerve endings would signal from the joint to the spinal cord, and that these signals will go back for immediate monosynaptic and fast reflex control of the wrist, but also for higher supraspinal control, so planning your motion. But we hypothesized this, we didn't actually know it. So we set up a study in 2010 where we wanted to look at the ligamentomuscular reflexes between the wrist, spinal cord, and the control of the muscles around the wrist joint. What we did was, using ultrasound, we inserted a fine wire electrode into the dorsal portion of the scapholunate ligament. The first test person was me, and this wrist right here, and it's still functioning very well. So using ultrasound, you see it in a transverse view, you see the scaphoid and the lunate, and you see how that needle is going into that dorsal scapholunate ligament. We would then electrically stimulate this ligament while monitoring the effect in wrist extensors and wrist flexors. So this is what it would look like. So we have the EMG pattern of a muscle before we stimulate the ligament. We would then see the stimulus artifact and then look at how that EMG pattern changes. So we have post-stimulus reactions. And when we look at this closer, we find that if you had the wrist in extension, then you would have an immediate reaction in the wrist flexors. Contrarily, if you had your wrist in flexion when stimulating the ligament, you would have an immediate reaction in the wrist extensors. So we call this a joint protective reflex. We also had a very particular reaction where we found that when stimulating the scapholunate ligament, we would get an inhibition of the extensor carpi ulnaris and an excitation in the wrist extensors. I'll get back to that later on because that is what we are using today for rehabilitation. So we do have joint protective reflexes in the wrist between the scapholunate and the ECU. In the shoulder, you have it between the coracoacromial ligament with a general inhibitory reflex arc of the shoulder girdle. And finally, we have one that we have just found between the dorsal ligament of the basal thumb and the APL muscle, the abductor pollicis longus. So we know that ligaments and nerves communicate to muscles, and that also skin contributes the sense of of proprioception, and all of this is, of course, processed in the brain. So based on this, I proposed a protocol for wrist proprioception rehabilitation, divided into 4 stages. Stage 1, basic hand and arm rehabilitation. Stage 2, conscious proprioception awareness. Stage 3, conscious neuromuscular senses. Stage 4, the unconscious. So we'll go through this step by step. Stage 1, basic hand and arm rehabilitation. It is just that, it's basic. It's about doing control for edema and pain. So why should we start with this? Well, if you look at a hand like this with massive swelling, you cannot start with very advanced proprioceptive rehabilitation strategies. Priority here must be to reduce edema and reduce pain. If you do not reduce edema and pain, you run the risk of developing what's called CRPS, or complex regional pain syndrome. But it is important to realize that even in a case like this with an obvious wrist injury, the development of CRPS is not just about the wrist. CRPS was first described by the father of hand surgery in Sweden, Professor Erik Moberg, in 1960. He did not call it CRPS at the time, but he called it a shoulder, hand, finger syndrome, because that's what it's about. Often this will start with a patient with a hand or wrist injury contracting the shoulder, not moving that shoulder. That shoulder contracture will cause a disturbance of the circulation of the upper extremity, which in turn will lead to edema of the hand, which will lead to scarring, and finally a frozen hand. Another Swedish orthopedic surgeon, Frickman, in his PhD thesis already in 1968, could prove that patients with a distal radius fracture would go from having a 10% risk of developing CRPS down to a 0.8% risk just by doing early elevation exercises and moving the fingers. So it is very important to remember that in patients that have a hand or a wrist problem, you should not treat just the hand, but you have to treat the entire arm. Of course, we also have to remember the interaction of the brain. So while we're treating the hand, wrist, and the entire arm, we have to involve the brain. And that brings us to stage 2, what we call conscious proprioception awareness. This is about getting control of your limb. It can be your upper or your lower limb. The conscious proprioception senses are, once again, tactility, joint position sense, and kinesthesia. It was First studied once again by Professor Moberg, who described the role of cutaneous afferents in position sense, kinesthesia, and motor function of the hand in a study published in Brain in 1983. He there said that fingertips are the eyes of the hand. And what he did was a study where he did a digital block around a finger, and then he would have a trial where a patient would try to replicate joint position sense and kinesthesia. What he found was that there was significant loss of both senses following a simple digital nerve block. He concluded by saying a finger without sensibility is functionally amputated. Well, I would like to go further and say a finger without proprioception is functionally amputated. So to train a conscious proprioception sense, you can use, for instance, joint position sense. What you're doing then is just asking the patient to replicate the angle of a joint. For instance, in the wrist joint, you can do a setting the wrist, for instance, in flexion, say 30 degrees of flexion, then you'll have the patient close their eyes and try to replicate that angle. You can work with mirror training. I'll get back to that. And finally, you can also work with kinesthesia, or the sense of joint motion. And that is something that you can do also by using kinesthetic taping. Mirror training is something that is quite important in hand therapy. This, for instance, was a 30-year-old right-handed woman. She was operated for a left-sided radiocollateral ligament injury of her first metacarpal joint. After 8 weeks of surgery, she had completely blocked away that thumb. She did not want to, feel that thumb, get that joint moving. So you can see here, she's doing finger flexion and extension, but she is not finding flexion or opposition of that thumb. What you do then is you place the patient in front of a mirror, and you will have the injured hand behind the mirror, and you will have the uninjured hand in front, and the patient will do physiotherapy exercises or hand therapy exercises. And as she's doing that, she's tricking the brain into believing that the hand is healthy. So this is what it looks like. After just 5 to 10 minutes of training, you can see how that left hand is now functioning normally, because she has tricked her brain into seeing that. And this is a type of proprioception awareness training. Another type of proprioception awareness training is something called cross-education. I'm sure a lot of you here who are so used to training sports injuries have used cross-education training. Cross-education is a type of neural adaptation that is defined as the increase in strength or functional performance, that is a skill, of the untrained contralateral limb after unilateral training of the opposite or the uninjured limb. There was a randomized controlled study in 2013 published in the archives of PMNR looking at the use of cross-education following distal radius fractures. They had a control group who were casted due to a distal radius fracture, and they did standard rehabilitation that started after the cast was removed. They then had a training group that, in addition to the training done after the cast was removed, started training the non-injured hand immediately following the fracture. What they found was that strength and range of motion was significantly better in the training group, the cross-education group, up to 12 weeks after cast removal. It's of course not just about the wrists. Here we have the famous Zlatan Ibrahimovic, our best soccer player from Sweden. And when he had his ACL injury, of course, it was important to get him going as soon as possible. So there was a study published in the KSSTA in January 2019, looking at how cross-education improves quadriceps strength after an ACL reconstruction. And they concluded from 48 patients that cross-education was very important in strengthening the injured limb by training the contralateral limb. What's interesting, though, is that just 1 month later in the same journal, another randomized controlled trial concluded that cross-education does not improve after an ACL reconstruction. So the question is, yes, in January 2019, no, in February of 2019. So does cross-education work or doesn't it work? Well, there is a bit of controversy around this. So in the Journal of Sports Medicine in 2021, they performed a Delphi study where they looked at, they interviewed 58 researchers on their thoughts on cross-education to set some key aspects of cross-education and how this can be studied. One, the definition is important. The cross-education effect should be used to describe the transfer phenomenon, which means that you're transferring strength and or skill by training one limb to the other limb. If you want to do some imaging to see the effect of cross-education, they conclude that functional MRI is the most promising to date. When setting up this study, you should consider using strategies that maximize the cross-education effect. For instance, high-intensity training, eccentric training, or mirror training. The study protocol should stretch over 13 to 18 training sessions or over 4 to 6 weeks. And it should primarily be implemented in unilateral orthopedic conditions and sports injuries. So, for instance, unilateral foot and ankle, knee, hip, shoulder, elbow, or wrist injuries. So enough about the conscious proprioception awareness. The stage 3 is the conscious neuromuscular sense, and the conscious neuromuscular sense is about training muscles that are good for you and not those that are bad for you. So this is something that can be used both following injuries and in patients that have instabilities based on, for instance, hyperlaxity. And the 4th stage is the unconscious neuromuscular stage, which is about reflex muscle activation. For the ankle or knee joint, you would do that on a balance plate. For the hand and the wrist, you're working with, for instance, this device called a true balance, where you're trying to find balance around the hand, the wrist, but you're also engaging the elbow and the shoulder joint. But I would like to get back to the clinical application of the conscious neuromuscular sense, because I believe that this is one of the most important stages that we work with, both as surgeons, but in particular as hand therapists or physiotherapists. Before we can look at how the muscles can be used in injuries or instabilities, we have to understand how muscle loading affects the carpus or the wrist joint. And there's one research group that has done phenomenal work in the world on this, and it's led by Dr. Mark Garcia Elias, my mentor and good friend. And together with Dr. Sava, Yup Esplugas, Pug, Fernandez, and Carreño, they have done fabulous work to understand how muscle loading affects the wrist joint. What they have done is they've set up a device where they use cadaveric specimens, and then they have sensors that are located around the carpus, and then they load the muscles around the wrist to see how it's moving. And what they have found is when you load wrist flexors and extensors, you're not just getting the wrist flexion and extension motion, but you're also getting an intracarpal pro and supination. So for instance, if you activate the APL, the abductor pollicis longus, and the ECRL, extensor carpi radialis longus, you will get a supination effect of the carpus. Contrarily, if you activate the ECU, you not only get a wrist ulnar deviation or extension, you also get an intracarpal pronation. So let's look at the most common type of ligament injury that we have in the wrist. That's the scapholunate ligament injury. And this is a video of one of my patients back home who's given me permission to show this. He is not a professional weightlifter, but he's very strong. He's a professional plumber and carpenter. And this is him sustaining a scapholunate ligament injury. And I don't know if you heard that crack, but that crack right there, that was him snapping off the scapholunate ligament. So the scapholunate ligament injury is a type of proximal row carpal instability that is belongs to the category of carpal instability dissociative. It means that when that ligament snaps, the bones are going to start going apart. You can see this by something called the Terry-Thomas sign. The scapholunate ligament injury and its occurring dissociation is by far the most common ligament injury in the wrist. It's very often missed, often caused by a forced hyperextension of the wrist, such as what he did just now weightlifting, but more commonly by a fall on an outstretched hand. It's often seen in contact sports or in arm wrestling. You diagnose it by using something called the Watson test. The Watson test is when you put pressure on the scaphoid tubercle and then you move the wrist from ulnar to radial deviation, and you will feel that scaphoid sliding out of the distal radius. Looking at an X-ray, if you have a static scapholunate dissociation, that means that the scaphoid and the lunate are always apart. You will see that the distance between those two bones is over 4 millimeters. You can also use dynamic fluoroscopy. So if you have a dynamic scapholunate dissociation, you will make an ulnar deviation and a fist. And what you can see here is how when that fist is made, the scaphoid and the lunate, they slide apart. I like to use ultrasound. So I use a lot of ultrasound diagnostics in my OPD, and looking at the scapholunate ligament is something that is quite easy to do using ultrasound. So you visualize it in a transverse view. Here you see the scaphoid and the lunate. Between those two, you have the scapholunate ligament, and you can evaluate the length and the thickness of the ligament as compared to the contralateral side. This, for instance, was a patient who had had a wrist distortion 3 weeks prior. The X-ray was negative, slight widening on dynamic fluoroscopy. He had pain over the scapholunate ligament, and using ultrasound, we could see that the distance between the two bones was 5.9 millimeters, which is far more than the 4 that is usually there. And we could also see these small chondral fragments in the joint. So I went on to scope and fix this ligament. But what about the muscle effect on the scapholunate tear? Well, what they did at the Barcelona research group is they simulated a scapholunate tear, and then they looked at the effect of muscles. And so when you're pulling on the ECU, the extensor carpi ulnaris, you will see that pulling on that muscle will open the scapholunate gap because it's causing an intercarpal pronation. On the other hand, if you're pulling on the ECRL and the APL, you will close the gap because it's causing an intercarpal supination. So I don't know if you remember, I said we saw an ECU inhibition when we stimulated the scapholunate ligament. That's because the body wants to stop that ECU action if you have a scapholunate ligament tear or injury. So once again, let's get back to training muscles that are good and not training those that are bad. So for the scapholunate tear, if you have a pre-dynamic or a dynamic instability, we're not talking about static dissociations or fixed DC deformities. You want to prevent intercarpal pronation. So you can promote instead intercarpal supination through isometric exercises of the abductor pollicis longus, which you want to do in a neutral forearm rotation, and the extensor carpi radialis longus and brevis, which you want to do in a forearm pronation. But not all wrist problems are injuries. We can also have wrist instabilities. And the most common cause of the effect of muscle action on wrist instability was studied by Alex Yuk, a good friend of mine in Barcelona. The most common type of wrist instability is the PALMAR midcarpal instability pattern. It is usually non-traumatic, and it's a non-dissociative wrist instability, meaning that it's an instability between the two rows of the carpal bones. So an instability between the proximal and the distal carpal rows. It means that you will see a clunking of the wrist as it's moved from radial to ulnar deviation. So you see how that wrist is clunking? It usually pertains to hypermobility, so it's more commonly found in young women. It's also more commonly found in the Middle East and in Asia as compared to Northern Europe. In a dynamic fluoroscopy, this is what it will look like. So you will see that the carpal row remains abnormally flexed until it clunks into extension at the end of movement. This is a multi-ligament dysfunction, and it involves a lot of ligaments in the wrist that have mechanoreceptors. So if we look at the muscle action in a patient with a simulated palmar midcarpal instability, Dr. Yuk found that the only action that could prevent the clunking of the wrist was activating the ECU. So if you pull on the ECU, you will get an intracarpal pronation, but you will also get an extension of the triquetrum. And if you add to that an isometric action simultaneously of the FCU, you will get a compression of the pisiform, which will again push up towards the triquetrum, and this will stabilize the wrist so you're not getting that clunking effect. So yeah, in these patients, they are non-traumatic, and for non-traumatic problems like this, you always want to start with conservative management and not operate on these patients. You will want to proprioceptively stimulate the volar and ulnar ligaments, and you should work to improve wrist stability through ECU, isometric exercises, and co-contractions of the ECU and the FCU, and add to that doing little finger abduction isometric training. But what about our athletes? Because we do see a lot of athletes, and what we want to make sure is that our athletes never end up with a wrist injury or wrist instability. So you can use these same concepts of proprioception in pre-season training. So stage 1, basic training. Stage 2, awareness. Stage 3, conscious neuromuscular control. And stage 4, unconscious. So for stage 1, basic training, it's just about strengthening that hand and that wrist to provide global stability and provide endurance. This, of course, is important in sports like boxing, MMA, martial arts, rock climbers who need a lot of endurance in their hand and wrist. Stage 2, proprioception awareness. Once again, we can use mirror training. Mirror training can be used to enhance the brain and the bimanual interaction. So in any sports where you're working a lot between the two upper limbs, mirror training can be a good option. For instance, of course, basketball, boxing, handball, etc. Stage 3, working those muscles that are good for you and not those that are bad for you, preventing injury. So you want to do targeted training, training of specific muscles that will prevent specific sports-related injuries. For instance, in tennis players have a lot of ulnar-sided wrist pain, and what they need to do is do ECU stabilizing exercises in their pre-season training. For golf, on the other hand, you want to work with both stabilizing the wrist and moving a lot between radial and ulnar deviation. So you're going to work the antagonists, FCR and ECR, but you're also going to work the antagonists in radial and ulnar deviation, so APL and ECU. And finally, stage 4, reflex training. Reflex training is just about that fast reflex upper limb control of both the hand, wrist, forearm. Of course, it will extend all the way up to your shoulder. So you can do that through working, for instance, a power ball, those gyros that start vibrating, so you have to stabilize the hand and the wrist. You can work with a frisbee upside down, rolling marbles inside, etc. The sports that are, of course, important for this include our goalkeepers, because they have to be very fast in their reflex control. Goalkeepers both in soccer and handball. Gymnasts, of course, need a lot of reflex control. So in the pre-season training for the injury prevention, you can use those 4 stages as well. So start with basic strength training, 2, proprioception awareness, 3, targeted muscle action, and finally 4, the reflex pattern of training. So this was just a brief overview of wrist proprioception, basic research, how it can be used in wrist injuries and wrist instabilities, and some thoughts on how we can interact with our athletes when it comes to pre-season training. So thank you very much for the opportunity to speak here today, and I'm going to hand over to Dr. Bashir.